Dr. Munnawar Shah for The Future is Here, in-office nanoarthroscopy.
Thank you very much. I just wondered, in the normal pediatrics, orthopedics, you asked me to do biologics. In the biologics section, you're now asking me to do nanoscope here. So it's just, I thought my sessions was done, but never mind, I'm still here. Okay, well, thank you for the opportunity. This is a technique that I've been doing for nearly 6 years now, right? And as I want to put a camera everywhere, this is one of the options that I was supposed to and delighted to start. So basically, all right, then that's fit in rightly, isn't it? Yeah? It plays here, okay. So this is what happens. You are an athlete and you do things that you shouldn't be, and you put your body into position where you shouldn't. And this is what happens, you hurt yourself, okay? And when you hurt yourself, you go to your local physician and you ask him, look, doc, I've got myself damaged, can you help me? And he orders some tests, okay? And the first thing to order in a shoulder, as far as I know about, is that you have to have an MRI scan, okay? And it's not an easy job. It's not just go MRI scan yourself and come back and we'll talk, okay? And that's where the problem starts. We have people with metal all over their bodies. We have people who have cardiac pacemakers. We have people who have neuroinhibitors, cochlear implants, pellets, too big, too small, and claustrophobic. Okay, so you can't have an MRI scan. So what to do now? Okay, and as it's rightly said, we have a problem. Okay, and this is an important statement that I always take myself, and it is applicable for all of you. If somebody offers you an opportunity to learn something new, do not say no. Say yes, and then learn and start doing it, because opportunity doesn't come twice. Okay? So this is the technique that we've adopted to. It's called nanoscope or needle arthroscopy, or MI. And it's basically a 1 millimeter needle that we put into any joint, for me, shoulders, and come out with amazing results. Okay? It's a 120 field of vision, not the 30 or 70, rarely that we use 70, mostly in hips, but it's a 120. And the reason I got used to it was because as a registrar trainee in England, you are given what is called an arthro box. And it's a needle to show you techniques. I think I've got a picture of it. Okay, we'll go, okay, don't have a picture of it. Right, so basically it is a 120-degree scope, and you are shown techniques for handling tissue inside a box. So this, for me, was not so, well, it was difficult, but not so difficult purely because I used to go on the teaching sessions for students, for the registrars, and practice this to show them what to do, and therefore it was an easy transformation. What are the indications in shoulders? As we already discussed, not a candidate for an MRI. Or it will eventually replace MR arthrograms. When you suspect a pathology, but the MRI scan that you've done does not confirm it, or you have done a procedure and you want to go in quickly and assess what's happening. In dislocation also, especially if you want to do a latter J in the future, you can go inside and assess bone loss directly rather than all the amazing mathematics that the guys in radiology use and tell you which is an on-track and off-track lesion, and this is what's happening, it's engaging and it's not engaging. And also, the most important indication I had was those difficult second looks. I mean, I could not justify taking them to the theater to do an arthroscopy because they was not doing well. Okay, and this is the implant. It comes in a straight needle. The camera has been developed really sensitive, and I first started diagnostics, but now we moved on to doing procedures on it, so it is an amazing implant. It's the future, I think, yeah. Okay, and now what has happened is instead of 120, the sheath has been twisted. So when you twist the sheath, the range becomes a lot better. Okay, and the way to do it is you put a local anesthetic into the portal that you normally use or would like to use for shoulder arthroscopy, and leave it for about 5 to 10 minutes. And then you push your needle more and then inject into the space, the shoulder joint. Okay, and once the patient is comfortable, you can continue doing your procedure. These are the portals that are used for shoulders, not too different from the one we have, just a slightly inferior. So this is the portal to use. So the thing that I've said a long time, and every time I come here, you must learn before you do. You can't do anything because somebody said it was sexy and you have to do it. Okay, you need to go through the process of learning. You cannot be unfair to our patients by just seeing it on a TV or an ad and continue doing it. So this is the message from here. It is a very good pathway. It shortens the process. You don't have to send them to MRI, bring them back again in the clinic, read them clinics, and then discuss it with them, and then send them for surgery. This is not cost. It doesn't make any money for the trust, so they don't like you to do all those things. You have an assessment, you assess, make a diagnosis, and proceed what you want to do. Okay, so this was my training. So I did it in office planning, then I did it on a cadaver, then I did it on a real person, but with an option to convert into an arthroscopy if I couldn't get in. Then I went to a lab, and this is a cadaver lab where we do arthroscopic assessment with a nanoscope. Okay, and like I said, we've started using instruments also. So in my life, nothing came easy, all right? And this is another statement that I quote is, adversity makes opportunity. Okay, and I used to fight with my managers for a nanoscope, and they told me to pee off, okay? Or, well, I wouldn't use a bad word, but they did not have any interest in me at all. And then this happened, COVID came. Right? And when COVID came, we could not do surgery. All the plan list was closed, and we wanted to move out as much as we could to somewhere else. So this is a GP theaters that was prepared by our trust for GPs who are keen to do carpal tunnel syndrome and injections and stuff like that. And because of COVID, this was empty, totally empty. Nobody was using it. And the next thing I know, 100 boxes arrived for nanoscope for me to do. And for me, this was an opportunity that was too good to miss. So we converted all our arthroscopic assessment that did not need procedures to this, including MRI scans that we could not do because of COVID, including the injections that needed arthroscopic supervisions. So this place started doing a lot of things that could have been possible because of COVID. Okay, so we started our first local anesthetic nanoscope arthroscopy in the clinic. Okay, and like I said, we did some local, pushed in the needle, and then inflated it with a syringe that got attached to the scope. This is another picture. Well, like I said, you can grab things, loose bodies, and pull it out also. So this is one of the first pictures. And funny enough, this is PRP being injected into the base of the tendon so that Khalid Saab is gone, but I was going to tell him that this is what we do now. We can do it with ultrasound, which is also an amazing advantage if you can read an MRI ultrasound. But for me, I can do both ultrasound and this, but for me, this is a lot easier. Okay, so this is a view of a bank card repair that we did, and as you can see, the knot is fraying, so this was the cause of the pain. And I don't have a video to show you, but we just put in one of those punches that you use, but on a smaller scale, and clear this up. This is a video of a slap lesion that being cut after a dislocation, so it was much better than the MRI scan you could see. And this is a torn cuff looking from the top, and the needle is an amazing instrument. We never thought that needle could work in surgery. Okay, yes, I did this, but I don't think so that it made any difference. And to do a chromium decompression on a needle arthroscopy, I think it's pushing the indications. Okay, so this is one of the first pictures we had. You can see a drive-through sign where you can see both ends of the glenoid and the humeral head outside and next to it. And that's where the bare area is, and it's a very nice picture. I'm sure it will give us enough information for us to be not worried that the nanoscope is a beginning thing. So again, I don't have a pointer, but the first picture is a cuff tear from inside. The second picture is a cuff tear from the top. And the third picture is a drive-through sign in an unstable shoulder. Okay, this picture, the first picture is a slap lesion. The second picture is the humeral head hitting the acromion because of instability. And the third picture is a labral tear. So there are questions. If you start something new, because of COVID, I went through all the hoops that people will do, but if you start, you will be asked, what's the complication rate? Why do you want to do this? The complication rate is very minimal, 0 to 1.2%, and the worst thing that can happen is you can't see what you want to see. That's the worst thing that can happen. So you can always go back to do standard arthroscopies or an MRI scan. Okay. And also, evidence has supported that either or in-office a nanoscope arthroscopy is more sensitive and specific than the MRI. And there is no ability to change the view angle, but people are working on it. This is 2025, and watch the space. This was the Arthrovax I was telling you. So this is a box that comes in. It's a 120-degree scope, and you put your camera inside. This is for all our registrars to learn arthroscopic skills. I think I left one with Zaid Askarsab for people to, and one Sufyan has, so you can always request them to show them to you and to play with it. There are concerns over infection, but very minimal. I mean, I've done, I think, 25, 26, and I have no incidents, but then tomorrow when I go, I'll find somebody's got infected. But so far, so good. And yes, if you're careful with sterility, because it's not in an in-theater, everything else is still sterilized, but the infection is a potential concern. Will we see what we want to see? And I think the answer to that is no. You cannot always see everything, so you may have to be prepared to take this and accept it. If we can't get in there, then we need to perform a degree of the debridement of the bursa to actually go and see. And that's not difficult because the instruments are cutting smaller and smaller and smaller, so we can use it. So what are the results? Well, my initial results. So I have about 25 shoulders that I've done. The age mostly was 40s, predominantly men, and not so heavy. And most of them were right shoulders. I'm not sure why. Okay, and what did we find? We find cuff tears, labral tears, and loose bodies. The loose bodies we took out. We did debride some of the labral tears that were not detached. And some of the cuffs we actually cleaned and tidied them up and then did PRP injections. Okay, well, it's just the same repeatment, but you need to wait 10 minutes before you can start doing this. Okay, so what are the disadvantages? There's discomfort occasionally. Some people have discomforts from this procedure, and there's also a learning curve. Okay, this is the way forward. Thank you.